Today I will be presenting on topic of complications of CKD. CKD is the major health concern all over the world, um, and the numbers of CKD patients are increasing over the period of years, reflecting the growing elderly population and this increased number of patients with diabetes and hypertension. So mostly I will be talking on complications of CKD, that is anemia, nutrition, cardiovascular risk, hyperlipidemia, and osteodystrophy related to the chronic kidney disease. So what is chronic kidney disease? Chronic kidney disease is defined as either kidney damage or a glomerular filtration rate less than 60 ml per minute per 1.73 meter square for more than 3 months. It is defined as pathological abnormalities or markers of damage, including abnormalities in blood or urine test or imaging studies. National Kidney Foundation categorizes the chronic kidney disease according to the severity of the disease into 5 stages. That is, stage 1 is with kidney damage with normal or increased glomerular filtration rate, that is more than 90 ml per minute. Stage 2 defined as decreased glomerular filtration rate between 89 to 60 ml per minute. Stage 3 as 59 to 30 ml per minute of GFR. Stage 4 as a severe decrease in GFR, that is from 29 to 15 ml per minute of GFR. And stage 5 as a end stage renal disease or kidney failure as less than 15 ml per minute per 1.73 meters square. So why chronic kidney disease is important to discuss in ICU setup. So there are an increasing number of patients with pre-existing renal dysfunction who get admitted to the ICU with acute illness. So this increased risk of acute kidney function deterioration, which leads to acute on chronic kidney disease. This is independent and strongest risk factor causing acute on chronic kidney disease. There are almost 12 to 35 patients in the ICU with chronic kidney disease, and 3.4% of ICU admissions with the chronic kidney disease patients into end stage renal disease. So, and the spectrum of end stage renal disease patient is totally different from other patients compared to other population, as these patients are more younger patients and they are twice associated with diabetes and peripheral vascular disease, sepsis, and they are mostly admitted with non-surgical cause. So why this chronic kidney disease patients are different? They are associated with higher comorbidities like diabetes, hypertension, peripheral vascular disease, malnutrition. Chronic kidney disease induces structural and physiological changes in other organ systems also. They pose high risk of early worsening of various organ functions in CKD patients. In these patients, pulmonary edema and sepsis are the most frequent causes of admission in the ICU, and cardiovascular causes and sepsis are the most common cause of death in CKD patients in the ICU. This chronic kidney disease has a systemic nature, that is energy balance, innate immunity, neuroendocrine control of organ functions. These are all highly integrated biological processes in human body, and this integration is disrupted by loss of kidney function, which leads to high risk clinical phenotype of chronic kidney disease. The clinical profile of chronic kidney disease includes inflammation, malnutrition, altered activity of autonomic and central nervous system, cardiopulmonary diseases, vascular and bone diseases. The gut and lung are the most critical mediators of the interaction between the kidney and the environment in the human body. So, how chronic kidney disease disrupts this energy and immunity link? So, there is also circadian rhythm association in chronic kidney disease related to the energy and immunity. So there are in daytime there is more of activation of sympathetic system, cortisol, glucagon, and cytokines at the molecular levels, and this related to the energy, there is increased lipolysis, gluconeogenesis, increased protein breakdown, and decreased lipogenesis in CKD patients. On the other hand, this reduced leukocyte redistribution and polyclonal antibody production in the CKD patients. There's also increased insulin production in CKD patients. In immune system, there's reduced antibody production, and there's clonal expansion of antigen-specific lymphocytes due to increased energy metabolism, like gluconeogenesis, increased ketogenesis. So the pro-inflammatory mechanisms in chronic kidney disease. So chronic kidney disease leads to reduced renal clearance of cytokines and sodium and volume expansion. On the top of with genetic background and epigenetic modifications causing chronic kidney disease, which leads to metabolic acidosis, insulin resistance, cell senescence, propensity to infections, and nocturnal hypoxemia, leading to sleep apnea in these patients. CKD also leads to bone mineral disorders, retention of uremic toxins that are absorbed from the gut, and periodontal diseases. The energy metabolism regulation, cardiovascular disease, and bone disease in chronic kidney disease patients. So, chronic kidney disease patients have altered levels of BMPs, that is bone mineral proteins, leading to bone diseases. Thus, decreased production of 125 dihydroxy vitamin D. That is, there is less hydroxylation of 1 hydroxy vitamin D and increased hormone levels. This also increased osteocalcin carboxylations and increased fibroblast growth factor 23. This all leads to hypertension, volume overload, and uremic toxins, which leads to cardiovascular diseases in chronic kidney disease patients. This also there's decreased insulin secretion and also decreased insulin sensitivity and altered energy balance and altered adipocyte function, leading to cardiovascular diseases in CKD patients. The gut kidney axis and the cardiovascular disease in the CKD. So, in intestine, there are more of uremic toxins because of decreased secretion through the renal due to chronic kidney disease. These uremic toxins are absorbed in the gut, in the circulation, and this uremic toxin retention due to chronic kidney disease, which causes further disruption of the intestinal barrier. And this high uremic toxin return uremic toxins um, causes inflammation, leading to cardiovascular disease, leading to heart failure, and again back to the disruption of the intestinal barrier. There's also translocation of intestinal biota because of the disruption of the intestinal barrier. So, overall, the changes in all systems due to CKD as a systemic disease. In cardiovascular system, there's left ventricular hypertrophy. These CKD patients are more found for the coronary artery disease, pulmonary hypertension, and dilated cardiomyopathy. In pulmonary complications, there are changes like pulmonary edema, pleural effusions, and these patients are more prone to develop obstructive sleep apnea, almost 60%. Immunological changes which happens in chronic kidney patients are this attenuated inflammatory and immunological responses, and there's high risk of infections due to immunity disrupted immunity in chronic kidney patients. This patient, chronic kidney patients, needs higher dose of diuretics to acquire the same effect as non-CKD patients. And there are electrolyte imbalances in your sodium, potassium, magnesium, calcium, and phosphates. In GI system, there's altered gut microbiome, poor GI motility, and the increased incidence of hepatitis B and hepatitis C infections. So, CKD associated anemia. So, anemia is defined by WHO as hemoglobin less than 13 in adult male and postmenopausal woman, and less than 12 in premenopausal woman. National Kidney Foundation defines CKD associated anemia as hemoglobin less than 13.5 gram per deciliter in men and less than 12 gram per deciliter in women. So this CKD associated anemia is most of the times normocytic normochromic anemia, and the overall prevalence of this anemia is almost 50%. This strong relation between prevalence of anemia and severity of CKD. So one quarter of stage 1 and half of those in CKD stage 2, 3, 4, and three-quarters patients starting dialysis develop CKD associated anemia. So there are multiple mechanisms for the development of anemia in CKD patients, like iron, folate, or vitamin B12 deficiency, GI bleed, severe hyperparathyroidism, systemic inflammation, or shortened red blood cell survival. But decreased erythropoietin synthesis is the most important and specific etiology of CKD associated anemia. Erythropoietin is a glycoprotein which is secreted by kidney interstitial fibroblast, which is essential for growth and differentiation of RBCs in bone marrow. In CKD, there's tubular atrophy, which causes tubulointerstitial fibrosis, leading to decreased production of erythropoietin. So this CKD associated anemia increases the morbidity and mortality from cardiovascular complications like angina, left ventricular hypertrophy, and worsening heart failure, which leads to vicious cycle leading to cardiorenal anemia syndrome. Left ventricular hypertrophy as patients with chronic kidney disease associated anemia developing left ventricular hypertrophy have a decreased survival when the patient is on dialysis. End stage renal disease with left ventricular hypertrophy patients have 30% lower 5-year survival rate than the patients without left ventricular hypertrophy. The anemia is an independent predictor of death in stable coronary artery disease patients with CKD. The treatment for this is recombinant human erythropoietin. It is replaced, this has replaced transfusion as the mainstay of treatment and improved the survival of improved survival of CKD patients. This normalization of hemoglobin levels is no longer a goal for the CKD associated anemia as per the COIR trial. The US FDA has approved target hemoglobin level between 11 to 12 gram per deciliter in CKD patients. There are multiple landmark trials in anemia and kidney disease patients. So, over the period of time, this normal hematocrit trial, which was published in New England Journal of Medicine in 1998, it has shown the targeting hematocrit levels. They studied, compared the hematocrit levels with administration of recombinant erythropoietin uh, with 42% versus 30% increase in hematocrit levels. So there was better quality of life with higher hematocrit levels, but it was associated with higher incidence of death and myocardial infarction. Then in 2006, there were two trials were carried out. The CREATE study has studied the CKD patients and non-end stage renal disease patients. They have studied with a higher hemoglobin versus uh, targeting lower hemoglobin, and in such patients with the cardiovascular outcomes. And they have found that normalization of hemoglobin to 13 is not should not be a goal, because it was associated with adverse cardiovascular outcomes. The another COIR study, it studied targeting higher hemoglobin and like 13.5 versus 11.3, and primary composite outcomes were death, myocardial infarction, heart failure, and stroke. So they uh, they have found that there was alarmingly association between higher hemoglobin with the primary composite outcomes. That is, achieving higher hemoglobin in 13.5 group, they found more incidence of death, myocardial infarction, and hospitalization. In a DRIVE study in 2007, they studied comparison of IV ferrigluconate to increase the hemoglobin in chronic patients uh, with the erythropoietin with the IV, and they found the IV ferrigluconate is effective in increasing hemoglobin levels uh, in the CKD patients. In 2009, the TREAT study was carried out, which had the goal of hemoglobin targeting hemoglobin 13 with darbepoetin, and there was no reduction in risk of adverse outcomes, but there was increased risk of stroke and thromboembolism. The pivotal study in 2019, which studied about the proactive use of injectable iron versus the reactive use of injectable iron, and they found the proactive iron strategy was associated with less cost and better outcomes. In 2009, they carried one study uh, regarding the hypoxia inhibitory factor, that is roxadustat, and it has shown that roxadustat has um, ability to increase hemoglobin to increase the hemoglobin at 1.9 versus the placebo group. So this is new upcoming therapy in anemia in chronic kidney disease to a study in extensive population. So another complication, chronic kidney disease and mineral bone disorders. So in chronic kidney disease, this decrease in bone formation induced by chronic kidney disease. So this osteocyte activation, which causes increase in fibroblast growth factor 23, which leads to decreased phosphate reabsorption and decreased calcitriol synthesis. This increased serum phosphate in CKD patients leads to increased parathormone and decreased serum calcium. This decreased absorption of phosphate and calcium from the gut. So, in CKD mineral bone disorders, this increased fibroblast growth factor 23, increased parathormone, and increased phosphorus. And this decreased 125 dihydroxy cholecalciferol and calcium, which leads to vascular calcification and bone diseases, leading to osteodystrophy in chronic kidney disease patients. So increased phosphate is a risk factor for mortality and adverse cardiovascular outcomes in CKD patients. The increased risk of vascular calcification and left ventricular hypertrophy in end-stage renal disease. It accelerates progression of renal failure. We can use calcium-based binders, and excessive the increased phosphate may be because of use of calcium-based binders and excessive vitamin D therapy. The principal goal of treatment is phosphorus level reduction. So restriction of dietary phosphate binders like calcium based versus aluminum based. Aluminum based uh, phosphate binders are no longer used that frequently due to aluminum toxicity. We can use calcium free non-absorbable agents like sevelamer, uh, then vitamin D and related compounds, and calcimimetics. National Kidney Foundation recommends to maintain serum phosphate levels between 2.7 to 4.6 mg per deciliter in stage 3 and stage 4 CKD patients, and 3.5 to 5.5 mg per deciliter in patients with stage 5 CKD. It also recommends to restrict dietary intake of phosphate to 800 to 1000 mg per day when serum phosphates are more than 4.6 mg per deciliter, or serum parathormone levels more than 65. Uh, it also recommends to monitor serum phosphate every 3 months in patients on phosphate restricted diet. The target range for corrected serum calcium is 8.8 to 9.5 mg per deciliter. If serum calcium is more than 10.2 mg per deciliter, then we need to reduce or discontinue vitamin D analogs and or switch to non-calcium based phosphate binders. The sevelamer is non-aluminum and non-calcium based phosphate binder. It traps phosphate in bowel through ion exchange and hydrogen binding. It is available as 400 mg and 800 mg tablets, um, and granule packets. The dose is 800 to 1600 mg 3 times a day with meals, maximum 13 grams per day. It has to be given with other drugs 1 hour before or 3 hours after the other drugs to be given 1 hour before or 3 hours after the administration of sevelamer. It stabilizes rate of vascular calcification. It has also lipid lowering and anti-inflammatory properties, and it also reduces fibroblast growth factor 23. It has side effects like nausea, dyspepsia, constipation, and it may cause hypocalcemia. The calcimimetic agents like cinacalcet, these are the calcimimetic drugs that binds to calcium sensing receptors on parathyroid gland. It makes parathyroid more responsive to the ambient ionized calcium, which suppresses the parathormone hormone. It decreases serum calcium and phosphate both. It is available as 30 mg, 60 mg, and 90 mg tablets. It is used in patients with hyperthyroidism where use of vitamin D is contraindicated due to hypercalcemia and hyperphosphatemia. It causes maximal parathormone suppression after 2 to 4 hours in stage 3 and stage 4 CKD patients. After giving cinacalcet, we should monitor serum parathormone levels 12 to 24 hours of the first dose. The cinacalcet is not recommended in non-dialysis CKD patients. The cardiovascular complications. The cardiovascular diseases, this conveys high risk for coronary artery disease, heart failure, arrhythmias, and sudden cardiac deaths. The most common cause of death in patients with kidney failure. Classical risk factors uh, uh, are present. Classical risk factors are responsible for cardiovascular complications in early stages of the CKD, while non-traditional risk factors are responsible for cardiovascular complications in intermediate and late stages of the CKD. This mild to moderate renal impairment is always associated with increased cardiovascular risk. So classical risk factors in CKD patients are hypertension, diabetes, obesity, and dyslipidemia. And non-traditional risk factors in CKD patients leading to cardiovascular complications are isosmotic and non-osmotic sodium retention, volume expansion, anemia, inflammation, malnutrition, sympathetic overactivity, mineral mode diseases, and uremic toxins. Hypertension is a hypertension. It is increased risk for new or recurrent cardiovascular events in patients with stage 2 or 3 CKD patients. Systolic blood pressure is more strongly associated with cardiovascular deaths than either pulse or diastolic pressures. The systolic blood pressure and mortality follows U-shaped relationships. That is, higher systolic blood pressure and low systolic blood pressures are associated with higher mortality. The National Kidney Foundation guidelines target um, blood pressure of less than 130 to 85 mmHg for all patients with kidney disease and less than 125 by 75 mmHg for patients with protein excretion more than 1 gram per 24 hours. So how the hypertension is caused in chronic kidney disease patients. So in chronic kidney patients, there is glomerular sclerosis, which causes reduced global glomerular filtration rate, which leads to reduced natriuresis, increased local synthesis of renin by juxtaglomerular apparatus, and this increased sympathetic drive, which is activated via afferent renal nerves. This also reduces nitric oxide bioavailability due to glomerular sclerosis. This reduced natriuresis leads to increased osmotic sodium accumulation and in extracellular volume expansion. Increased local synthesis of renin leads to increased local and systemic angiotensin 2, which further leads to increased tubular sodium reabsorption and extracellular volume expansion. Due to reduced nitric oxide bioavailability, there is endothelial dysfunction. All these things leads to increased vasoconstriction, leading to hypertension, increased osmotic sodium accumulation, extracellular volume expansion, and increased non-osmotic sodium accumulation, which causes increased arterial stiffness and hypertension. Diabetes mellitus is also associated with adverse outcomes in all stages of chronic kidney disease. Lower fasting plasma glucose and or lower glycolated HbA1c has lower risk of mortality in chronic kidney patients. Anemia and hypertension, they play a role in development of left ventricular hypertrophy. The abnormal serum phosphate levels, calcium phosphate ion product, and parathormone, these are independent cardiovascular risk factors in stage 5 CKD patients. Serum phosphate levels are associated with increased rates of death and myocardial infarction in stage 3 and 4 CKD patients. This European Society of Cardiology has published one article, that is review article, cardiovascular complications in chronic kidney disease, and it mentions hypertension, diabetes, uh, obesity, dyslipidemia as classical risk factors, and non-traditional risk factors like retention of sodium, sympathetic hyperactivity, and other factors as discussed earlier. This uh, association of diabetes mellitus and chronic kidney disease and obesity. So the risk factors for the diabetes dependent mechanisms are obesity and diabetes dependent adipokines derangements in CKD patients. There is also hyperglycemia and advanced glycation products in CKD patients. The CKD dependent mechanisms are sodium retention and volume overload, anemia, hyperphosphatemia, vascular calcification, and secondary hyperparathyroidism in CKD patients, high renin and aldosterone, and accumulation of uremic toxins like inhibitors of nitric oxide synthase, that is asymmetric dimethylarginine, ADMA, trimethylamine dienoxide, and others. The overlapping mechanisms in diabetic kidney disease are insulin resistance, dyslipidemia, arterial stiffness and hypertension, altered gut microbiota, inflammation and oxidative stress, endothelial dysfunction, hypercoagulation, and autonomic imbalance and sympathetic overactivity. The inflammation also plays role in cardiovascular risk in CKD patients. There are elevated markers of inflammation in CKD patients. The CRP, there are many studies showing the CRP, which predicts cardiovascular outcomes in CKD patients. The high CRP is a independent predictor of all-cause mortality. By a study in study modification of diet in renal disease study by Menon. And proteinuria is also hallmark of renal impairment, which is associated with increased risk of cardiovascular disease and early cardiovascular mortality in these patients. HOPE study, that is Heart Outcomes Prevention Evaluation, uh, has showed that there's increased relative risk of PMI, stroke, and cardiovascular death in microalbuminemic patient, that is more urinary excretion of albumin of more than 30 mg per 24 hours. Dyslipidemia is a major risk factor for cardiovascular morbidity and mortality in CKD patients. Hypertriglyceridemia and LDL cholesterol, there's increase, they are proportional increase to severity of renal impairment. Chronic kidney disease has a reduced lipoprotein lipase and hepatic triglyceride lipase. A hyperparathyroid hormone, and accumulation of calcium in pancreatic islet cells, which leads to dyslipidemia in CKD patients. The SHARP study, that is study of heart and renal protection, um, studies about role of statins in reducing major atherosclerotic events in patients with CKD. So National Kidney Foundation guidelines suggest that all stages of CKD are equivalent to cardiovascular disease risk equivalent. The target LDL level should be less than 100 mg per deciliter. If the LDL levels are between 100 to 129 mg per deciliter, then lifestyle changes is the mainstay of the treatment. If the LDL levels are more than 130 mg per deciliter, then statin should be used as the initial therapy to reduce dyslipidemia. If the triglyceride levels are more than 200 mg per deciliter, then goal should be to achieve non-HDL level less than 130 mg per deciliter, and both lifestyle changes and use of statin should be implemented. Electrolyte disorders. The metabolic acidosis is most common metabolic disorder in CKD patients. This acid in this when it happens because of acid intake and generation exceeds the renal acid excretion. The chronic metabolic acidosis leads to skeletal muscle catabolism, um, insensitivity to endocrine hormones, bone disease, accelerates progression of CKD. CKD patients have also disorders of sodium, potassium, calcium, magnesium, and phosphorus. Early detection and accurate management is is important in CKD patients. The uremic symptoms like anorexia, fatigue, cachexia, pruritus, nausea, restless leg syndrome, and sleep disturbance are also observed in CKD patients. The nutritional issues. This altered nutritional requirements in CKD patients. Metabolism of protein, water, salt, potassium, and phosphorus is affected, leading to uremic malnutrition. Thus, inadequate nutritional intake and also ineffective nutrient utilization in CKD patients. The maintenance of neutral nitrogen balance is important in CKD patients. Low serum albumin is highly predictive of poor marker of general clinical status. Uh, National Kidney Foundation recommends the maintenance of serum albumin level 4 gram per deciliter or greater in stage 5 CKD patients. That's all about, sir. I read about, sir.
Hello.
Hello.
Yeah. Hi. So I think it was a good job overall. But tell me, how would you like to summarize your talk in the next 5 minutes? Summarize whatever
Uh,
you do. That is easily
okay.
understandable to everybody.
Okay. So chronic kidney disease, the chronic kidney disease patients, there are increased number of chronic kidney disease patients admitting to the with critical illness in the ICU, and we need to uh, address these patients proactively in terms of complications. Like we should always uh, target near total hemoglobin in CKD patients to avoid to slow the progression of CKD patients. Plus, in terms of cardiovascular complications, there should be use of lifestyle changes and use of statins, uh, early detection of metabolic acidosis, and correction of electrolyte abnormalities, and involvement of dietitian and proper calorie and protein requirement. Early assessment of nutritional status of such patients can slow the uh, disease progression in CKD patients.
You know what I feel? I feel we are confusing two things here. One
Yes, sir.
is the CKD patient coming to the ICU. What are the challenges while managing him in the ICU? That is one part.
Okay.
And
Okay, sir.
CKD, care of CKD out of ICU is another part. So
Okay,
we
sir.
are mixing the two. So when we speak
Okay.
about caring for a CKD outside of ICU, we talk about traditional and non-traditional risk factors.
Yes, sir.
Traditional means the ones included in the Framingham Heart Score. Non-traditional are the
Yes, sir.
calcium, phosphorus, PTH,
Yes, sir.
that Monkeybugs calcification,
Mm.
reverse epidemiology. All those things are non-traditional.
Yes,
And
sir.
traditional is LDL, all your cholesterols, triglycerides, blood pressure, diabetes, smoking. That is traditional. So that is
Yes, sir.
about CKD care in the community. Now,
Mm.
CKD care in the hospital, in the ICU, when they come to us is different. CKD care, when they
Okay,
come
sir.
to us in the ICU, most important for us is volume, blood pressure,
Yes, sir.
making sure that we are correcting the hyperuricemia to prevent any flares of gout there, and
Yes, sir.
looking after the iron metabolism and anemia.
Yes,
These
sir.
are important for us in the ICU. What is important for
Okay.
us to understand is to avoid using blood transfusions in these patients, because some of them might
Yes.
want to go for transplant tomorrow.
Mm.
Iron usage, we should know that iron in an active bacterial or fungal infection should not be used. Whereas if the patient is not in sepsis, iron can be used in the ICU. Fungal is a
Okay.
strict no because mucor lives on iron. It's the Siderophore, right?
Yes, sir. Yes, sir.
And bacteria is 50-50. But normally in sepsis, most people would not want to use IV iron.
Yes, sir.
Erythropoietin is good. The reason most of us don't use it a lot is because of the erythropoietin resistance, because of the infections and everything in the ICU. So we end up using a lot extra dose, but I think it is worth using the extra dose to get the anemia under control, because the anemia worsens, then we need blood. So we should try and
Yes,
avoid
sir.
blood transfusions by using more. The volume
Yes, sir.
status is important because on one hand, in CKD, you are trying to avoid diuretics to prevent rise in urea and creatinine. On the other hand, in the
Yes.
ICU, we don't like patients with volume overload.
Sure,
So
sir.
maintaining the patient in equal volume balance is important. Okay. So these are the points that I would like you to take home, because
Yes,
we
sir.
should not mix the two issues: critical care, critical care and CKD care, and CKD care in the
Okay.
community. These are two different things. Okay. I
Okay,
think
sir.
otherwise you have
Okay,
done a
sir.
good job covering as per the book what is CKD care. Okay. Sure.
Okay, sir.
Sure.
Okay. Thank
Okay
you,
then.
sir.
Bye.
Thank you, sir.
Thanks. I'll close.